as Dr. Phan's brain is, it's not as good as having 100 kids in a database that we can pick up patterns with. So we've got to get these kids into a database so that we can pick up patterns and understand these nuances. The database is ready. Besides picking up patterns, once we have the kids in the database, thinking about if we have a drug to do clinical trials, instead of saying, well, let's just try this. How many times have you heard that? Let's just try this. Well, let's just try this, but let's try it in a way that we understand it. So we now have a tool that we can do this. We've got to get kids into the database. And then once we get them in, it's much more easy to get grants. So this is an exciting step. We're ready for this. It's critical. This is how we're thinking about it, because I get the question, well, how do I get my kid in? So the major hubs are the blue stars that I showed you. They're acting as hub, but these satellite sites, you can be seen by your pulmonologist, but the satellite sites can work with the major hubs, and the hubs will upload your data. There'll be consent forms to sign, but this is how we've structured it, kind of a hub and spoke network, so we can capture everyone. I should mention that the Europeans, the UK, just got a large grant to do identical to this. They will be setting up a huge database in the UK. You'll be part of that. I keep trying to figure out how we get part of that money. I haven't figured that out yet. And the Euro's not doing so good, but it appears to be doing good for rare disease, so we're happy about that. But that's exciting. And so just to give you an idea, since 2004, and frankly, this is more than we could have ever imagined in 2004. Am I speaking truthfully? I mean, this is incredible. So we've gone from single centers, no definitions, no registry, no collaborations really between institutions, no ICD-9 codes. That's really important because that's how you bill and that's how you document in medicine. Grants, our consensus statement, no clinical trials, and in really a relatively short period of time, we have all this now. It's incredible. And it's because we've joined together with you and these other centers, and we're tired, and it affects us to have to look at, multiply you by 100 that we have to look at and say, we don't know enough. And it really impacts you over time. So this has been incredible. And these doctors in the room, this isn't like asthma or CF where there's a lot more funding. These guys are not funded to do this. So to do more, we have to do better. But it's been because people are passionate, committed to really finding a cure for this, all of these conditions, and being with you as a family. So no clinical trials, but that's the next frontier. And so together, that's my ending point, together. And it really is together, because never underestimate the power the families have. You have a tremendous amount of power. We're just simple little lung doctors or neonatologists. But you have tremendous power to tell your story, to demand that people be interested. And so having you with us has made all the difference in the world. So with that, I want to stop. I've probably gone over, but we started late. I want to point that out. But I wanted you armed with some of this information. To talk to people you'll hear on Facebook, to understand that's a little different, but also to understand why we're all here together and how we're stronger together. Okay?
This is regarding the pulmonary hemorrhaging. Do you see that do they lack clotting factors? Are they chronically anemic? And would something like, say, vitamin K, which can actually help your clotting factors, be any kind of benefit to these children?
What do you do for a living?
Veterinary.
She's a dog nurse.
She's a dog nurse. Okay. Something here that asks those questions. So those are very good questions. And usually when we see a child with pulmonary hemorrhage, that's one of the first things we do, is we check to see if their system can clot right or if they have normal clotting factors. So that's very common. But many of these kids, they may not, because they have an autoimmune disease that's getting rid of them, or it may be normal, and they have something attacking the capillaries in their lungs. So there are different ways that you can get to this. But checking their clotting factors and that whole system is a common thing we do. And yes, children who have low-grade bleeding in their lung can be chronically anemic. It's one of the signs we look for. Megan, do you want to add anything to that?
Anybody else have questions?
I might say that some of these disorders to diagnose with these pulmonary hemorrhages can be hard. to do. And why I asked Megan is the pathologist, when you're doing it again and again, where many of us here are proponents, this is a disorder we have to have a lung biopsy in. Because knowing if something's attacking the capillaries in your lung is critical. That is a life-threatening condition, and you need very aggressive drugs. And it's a condition that's not recognized that commonly either. So an expert pathologist has to be involved.
I want to interrupt the questions, but I'm going to go ahead and load this so
Yeah.
we don't have to take time for me to be doing that.
Just a quick question. How do you find, I'll backtrack a little bit. We've been told several times that although our family has familial autoimmune diseases in our family line, that is not a connection to, say, knee-high and LIP and some of these others that are kind of somehow talking about autoimmune, but then when you ask, well, is that affected by a familial line, they say, well, no. What have you learned about that so far?
So actually, that's a very good question. And I would never say no. I would say we don't know. Okay, there's a difference. And there are many conditions, some of these lymphocytes, so some of these cells in the body that end up in the lung, with LIP, for example, we do believe that there can be associated immune deficiency or potentially an autoimmune problem. So we always are thinking about that when we see that could be a possibility. Sometimes in young children, it's the first thing that's manifesting of another disease that's coming down the line. We just don't know. And so sometimes we give it a diagnosis, we can't find anything, but later something might come and people go, oh, now I understand that diagnosis. Now, the knee-high connection, I really don't know about that. But what I say to you is that's why we need a database, because we need to have that variation in the database to know, is that a component of knee-high, or is that just two diseases in one place, and maybe you have knee-high and an autoimmune, you can have two diseases. We doctors hate that, so we never are thinking about two diseases at once. But it's possible. But that's the value of the database, to answer that question. And so I never say, no, it's not related. I'd say, I don't know enough to know if it's not related. And that's why we need in the database, because sometimes there can be other connections that we go, oh. And I will tell you that as we grow and see more cases, we're going to see those relationships. And maybe it's a subset. Medicine is not easy. We like to say it's this or this, but there are subsets even in that. And ultimately, we've got to get to how it's personalized to your child.
Speaking of the database, I guess the first question is, have the hub centers begun inputting kids into the database? And if you're at a satellite center, or even farther beyond a satellite center, some of these remote people that live in more remote areas, what's the best way for them to get the information to their doctor, to get it to a hub center, to get it into the database?
So right now, the little circles that I showed you on that map, to do this is a research effort. So you have to go through your institution and you have to tell them you're doing this research. And you guys, right now we're doing it on past records, and very shortly there'll be a prospective. So you'll sign to say, I want my child to be a part. And once you sign that, and if you're at a satellite, sign that, then your medical records can come into a hub center, and that hub center can upload your data. Now, some hub centers may not have the same level of support to do that, so we may have super hubs, I don't know, because it does take effort and does take people time to do that, but that's one of the things we're working with the foundation. So my comment to you is that's how it's going to work. Stay connected to the Child Foundation, because there'll be blasts going out when all this is ready, and we'll give you opportunities to make connection with different hubs. Because I think ultimately, over time, it may be of value to be seen at a hub center once a year. A, maybe that's when your data gets uploaded. B, you hear about the latest thing. And C, you have this whole multidisciplinary approach that individual satellites don't have because of resources or concentration of these problems.
Two quick questions. One, you said things that you see later down the line. Can you talk a little bit about that? And the other one is the mortality graph that you showed us. Is this only from 2004 that they've been able to track this? So there's always a question mark about later on, or is that kind of from before that? I don't know.
So that graph was from our paper, and that paper was published in 2007, and so that data was from 2004, 2005. So We have not re-looked at all those populations as a mortality since that time, but if you're in a database and tracking things, that's what you can do. And what I'm talking about later is that some of these immunologic, LIP, follicular bronchiolitis, may not have a diagnosis now, but later may have an autoimmune component. With knee-high, we don't know what it's going to look like with how their breathing's going to do down the line. We have to track that. Surfactant, we have kids who seem to get better, but what does it look like? They still have lung disease. That all the natural, we call that natural history, and we have to have that in the database to define it. And then if it's in the database and we are enrolling, the docs in the network are enrolling, we'll capture issues of difficult chronic disease or mortality. At this point in time, I don't really think of it being much different than that chart right now. Yeah. Anybody, you guys? Lisa?
Just to add, that study was only kids who had gone to lung biopsy from a certain number of centers and had had their lung biopsy done before 2 years of age. So particularly for the surfactant mutations, there are some very important differences.
Do you guys have anything to add?
Question about the database. Is it, at some point, are you going to track only children that have been diagnosed with a disease, or for genetic reasonings, are you going to track siblings and family members and maybe go back further in lineage?
So that's a very good question. And right now, we are tracking unknowns, okay, in the individual centers. So we will group them together. And then with surfactant protein mutations, there may be kids who have one mutation but not two, but have lung disease, and we're very interested in what that looks like. And there may be knee-high who had one mutation, and we got to understand that. So we're not losing track of that. The kids can come in. Now, I should mention the individual center will have a lot of flexibility for how they look at their database and use their database. That's their data, okay? So they'll own that. And they can have people put in. In some of the, we have the ability to take family histories on all the people in the family to capture if they have lung disease. But we will not be following, like if you have a lung disease and going to the doctor every 2 months, we're not going to capture every 2 months of data that you've got when you go to the doctor. But we'll capture your disease and what it is and the sibling's disease and if anything changes to absolutely try and get a handle on if there are other associations. Aaron?
If I could add to that.
Yeah.
So there are many of us around the country who are interested in some of these familial cases as well. And so there will be specific studies that are interested in enrolling family members, especially asymptomatic family members who so that we can start to really track, because my guess is there's some asymptomatic people with mutations who have, we don't know what the impact of that is going to be. The other comment I wanted to make is that, you know, this is a good chance for all of you to be advocates as well, because there are many times that we can make a diagnosis in the family on the basis of the child. And so, it's important that especially if you have a family history of some kind of problem, and you're getting a lot of these I don't knows, keep pushing your child's doctors so that they keep thinking about it and never kind of lay the issue to rest, because those kinds of families are going to be most informative and really trying to help us understand some of the new causes of disease.
Okay.